Hello everybody. So in this video we'll be discussing about the differentials of a white membrane which is seen over the tonsil. So commonly it is seen in acute tonsillitis, and a white membrane over the tonsil with redness all around it uh, is an important sign of acute tonsillitis. But this membrane can be found in numerous other conditions also, and we'll be discussing it one by one. So the first differential is diphtheria. It is caused by the organism Corynebacterium diphtheriae. It is a gram-positive bacterium which has a peculiar pattern of arrangement, which we also known as the cuneiform pattern or the Chinese letter pattern. So this commonly is seen in children, and usually these children are unimmunized, and this condition is quite rare nowadays because of the rapid immunization. And clinical features include exudative pharyngotonsillitis. So there are exudates which are formed on the pharynx and the tonsil, and there is a low grade fever. It usually do not exceed 38 degrees Celsius. There is malaise and pharyngitis. In addition to that, there is a dirty gray pseudomembrane. So when this organism it actually infects the upper respiratory tract. So subsequent to infection, it starts eroding the epithelium which is present over the tonsil, and it leads to ulceration. And following that, there is an inflammatory reaction, and there is deposition of fibrinous exudate over that ulcer. And subsequently to that fibrinous exudate, there is attachment of the leukocytes and the bacteria. So it leads to the formation of a pseudomembrane. Now this pseudomembrane is can be it can be differentiated in many ways from the membrane which is seen in acute tonsillitis. One, it is not only confined to the tonsil, but it is spreading to the soft palate and the posterior pharyngeal wall. Okay, so it will be spreading to the soft palate and the posterior pharyngeal wall. Further, it has a firm leathery texture, and it is not easy to remove this membrane, and on attempt of removal it starts to bleed. Whereas in acute tonsillitis, the exudate can be easily removed even through a throat swab. Then another appearance or sign which is seen in diphtheria is bull neck appearance, which is due to the enlargement of the jugulo-digastric group of lymph nodes. So the same lymph nodes is involved in the acute tonsillitis also, but there the edema is not, or the swelling is not as extensive as is seen in case of diphtheria, and bull neck appearance is seen even in mild cases of diphtheria and is quite common. So here we can see that there is a tough leathery membrane which is present on the tonsil, and it is spreading to the soft palate, and here there is a child having a bull neck appearance. Then this bacteria, the major complications that arise due to diphtheria are due to the production of an exotoxin, and that toxin, it goes into the blood and it starts involving multiple organs, and out of that, heart is one of the most common organ to be involved, and it leads to myocarditis, and subsequent to myocarditis there is arrhythmias and acute circulatory failure. Then there is involvement of multiple nerves in the body. So there is involvement of the cranial nerves, the sensory nerves, and even the autonomic nerves. So there will be varied manifestations, but the more common amongst them is paralysis of soft palate, diaphragm, and ocular muscles. Then this membrane, it goes deep and obstructs the larynx and the tracheobronchial tree, leading to respiratory obstruction. And whenever there is a respiratory obstruction, tracheostomy needs to be performed. Otherwise, the mode of treatment is penicillin or erythromycin given for a period of 7 to 14 days. Antitoxin should be given as early as possible to prevent the complications, and usually within the first 48 hours, and the dose is 20,000 to 40,000 units, which is given IV. Now we come to the second differential, that is the Vincent's angina. It is caused by the organism Borrelia vincenti and Fusobacterium species. Now this is also known as the trench mouth and acute ulcerative necrotizing gingivitis. So initially the patient has complained of bleeding gums, swollen gums and foul breath and bad teeth. There is ulcerations which is present over the gums, and later if this disease is left untreated, those ulceration can spread to the hard palate, can spread to the soft palate and even can involve the tonsils. So, and in response to that there is an inflammatory reaction leading to the deposition of grayish exudate over the tonsil, which we can see in this picture here. And here is a picture of Vincent's angina where there is ulceration over the gums, there is bleeding from the gums, and we can see a ulceration which is present on the hard palate. And this condition is usually seen in people who do not maintain a good oral hygiene. So this was one of the differentials of a membrane over the tonsil. And now the next differential is infectious mononucleosis. So this is a viral infection which is caused by Epstein-Barr virus, and acute tonsillitis was seen in mostly children, and here it affects the young adults between 15 to 20 years of age, and it spreads through oral secretions. Then again it has a long prodrome of 1 to 2 weeks, whereas acute tonsillitis is abrupt in onset. There is a triad of fever, pharyngitis, and posterior cervical lymphadenopathy, whereas in acute tonsillitis, the anterior group of lymph nodes are involved more commonly. Both the tonsils here are very much enlarged, congested, and covered with a dirty gray membrane. Also, there is petechia which is present over the palate, and they are quite specific for infectious mononucleosis. In 50% of the patients of infectious mononucleosis, splenomegaly and hepatomegaly is also present. Diagnosis. So usually there is raised total leukocyte count in the second week. In the first week, the TLC count is normal. Atypical cells in the blood smear are more than 10%. These atypical cells are nothing but they are enlarged lymphocytes. Then in the Paul Bunel test, there is a high titer of heterophile antibodies. So in EBV infection, antibodies which can react to the antigen which is present on the sheep's RBCs are produced, and those are known as heterophile antigens, and in response to them heterophilic antibodies are produced, and an increased titer of such antibodies is seen in Paul Bunel test, which is indicative of infectious mononucleosis. However, this test is not very sensitive, and other tests such as viral capsid antigen tests are used, which are more sensitive. Then treatment, it is a self-limited condition and it resolves in 2 to 4 weeks. Only supportive treatment is required. If there is secondary bacterial infection, then antibiotics are given. However, ampicillin and amoxicillin is avoided because it can lead to skin rashes in these patients. Now the next two differential, that is agranulocytosis and leukemia, is quite rare, and in both these conditions there is ulcerations in the oral cavity, and in response to that ulceration there is a membrane which will be formed over the ulceration as a healing process. So that will mimic the membrane which is seen in case of acute tonsillitis. In agranulocytosis, there is an ulcerative necrotic lesion in the oropharynx, and the patient here is severely ill because his immunity is severely compromised. The total leukocyte count is less than 2000 and can even be less than 50. The differential leukocyte count drops down to less than 5%. Leukemia, the total leukocyte count will be more than 1 lakh. Anemia is almost always present, and blast cells are seen on bone marrow examination. Also, in both these conditions, since the immunity is very much compromised, there will be recurrent infections from the bacterial and fungal infections, which will lead to the formation of which can lead to the formation of exudate over the tonsil. Then there is aphthous ulcers, the traumatic ulcer. So any ulcer, again, if any ulcer is produced over the tonsil, it will heal by the formation of a membrane. And the causes, however, differ. In aphthous ulcer, it is mainly caused due to nutritional deficiencies such as deficiency of folic acid or vitamin B12, and it can also be caused due to increased intake of acidic food, or increased stress might lead to abscess ulcer. They are benign and non-contiguous ulcer in the oral cavity, oropharynx, or on the tonsil. They are very painful. And traumatic ulcer is caused due to the trauma. It can occur due to toothbrush or any foreign object such as a pencil or fingering in the mouth can lead to traumatic ulcers. Then the last differential is candidal infection. So candidal infection is seen in people who are immunocompromised and who are using steroids for a long time, or steroid inhalers. So usually the people who are prescribed steroid inhalers should rinse their mouth thoroughly after the use of steroid inhalers, and if they fail to do so, they are predisposed to getting a candidal infection. Here, the membrane usually has a creamy consistency, a paste-like consistency, which is present over the tonsil and can even be seen on the soft palate or the posterior pharyngeal wall. Uh, like diphtheria, here also the membrane is difficult to remove, and on attempt of removal, it leaves a raw bleeding surface. So these were the different differentials of white membrane. Uh, Thank you.